Hi there. Today's title of the webinar is called Grit and Grace and the Goal to Breastfeed. And my name is Elisa Doherty. I am an occupational therapist and also an IBCLC. Thank you for joining us today. And thank you so much for your shared interest in the care of babies and how we best feed them. My disclosures today are I have no financial disclosures and no non-financial disclosures. Our learning objectives for this course are, after attending this webinar, the participant will be able to list at least 2 criteria of infant feeding development that impact the long-term success of breastfeeding and offer predictability of goal achievement. You'll also be able to differentiate from maternal descriptors 2 attributes that enhance the mother's ability to breastfeed. You'll be able to identify 3 challenges that predict potential barriers to the success of achieving the long-term goal of breastfeeding for the NICU infant. And you'll be able to relate at least 2 interventions for specific deficits to improve that infant's latch for effective milk transfer and reducing the maternal pain during breastfeeding. So a little bit about me. I received my bachelor's degree forever ago at St. Louis University, and I have been working dominantly in infant feeding, including the NICU and outpatient infant feeding for the past 19 years. So I guess not forever ago, 2003. I am an IBCLC with a specialization in occupational therapy as it relates to all areas of infant feeding, comprehensive of both bottle and breast. I'm the mother of 4. Those are my kids in that picture. They are all celebrating birthdays. So we've got 16, 14, 11, and 7. My husband just also happens to be a physical therapist. So we complement each other well, although he wants nothing to do with the baby population and focuses more on the sports injury, which he loves. I am a parent advocate. I love and understand the need for a parent to want to do best by their baby. And I feel that as a feeding therapist, our best way to care for those babies is to also care for their parents. Hopefully you agree. So why we do what we do, there is a vulnerability about having a baby that no one can quite adequately prepare you for. I know I experienced it. And even for those who haven't experienced it personally, I'm sure you've seen it or seen someone go through that change. All mothers have a desire to care for their babies. So kind of where I have to also take you back in a little bit about myself is I feel like I kind of stumbled upon this practice. As a NICU therapist, I always felt like I wanted to best care for babies, and I wanted to do that beyond personal experience when it came to breastfeeding. So my lactation certification comes from that desire to offer best practice. And so I am fortunate to be able to work within a population where I do find majority of moms do want to breastfeed long term. And as a clinical therapist in a NICU setting, that was hard. That was hard for them. It was hard for me with 4 full-term babies. So I really wanted to be able to break it down. And that was through, with great management support at our hospital, I was able to start the outpatient feeding clinic and was able to build a team along the way and learn so many things, which I hope to be able to share with you all today. So we need to know the goal. We need to know that breastfeeding isn't for the faint of heart. There's a lot of grit that will take us there, but the goals are constantly evolving. Every mother dreams of a healthy baby, and oftentimes the NICU stay is not part of the plan. Maybe they knew it was going to happen, but it certainly wasn't a part of their plan. What course would that baby have taken if they had been born term? Does that baby have medical conditions and developmental limitations? And how do all these things together impact that baby's feeding? So there's so much to think about when we talk about big picture, which was what we're kind of called to do. But when we start to break it down in all of the values that bring us to that finish line, all the variables that contribute, that's what we're going to talk about today. So defining grit. Why do we breastfeed? I will say that when I started in the NICU 19 years ago, it wasn't as popular. Pumps were something that you had to buy on your own. Insurance certainly didn't provide it. And so if a mom wanted to breastfeed, well, good luck, right? So we had lactation support, but to what degree? So some moms are trying to breastfeed because of nutritional reasons. We all know those. Financial, convenience, bonding, immune health, or all of the above. And throw in a formula shortage recently. Now we're really motivated. and feeling a little guilty if it doesn't work out. So what are the hierarchy of goals? Which one of those things, and maybe all, but which one drives that goal? And how does that family life balance fit into the feeding plan? So it can be very overwhelming. And our job as therapists is to build short-term goals that are going to allow us to get to those long-term goals so that we afford little wins along the way. So I titled this webinar and started working on it, and then found myself last weekend on a family road trip and looking for an audiobook to get me there. Found Angela Duckworth and her book called Grit, The Power of Passion and Perseverance. And I haven't finished it, but I could not believe the first chapters in her definition of grit and how applicable it was to the parent and specifically to breastfeeding. You have to really want it. You have to be able to work very hard. And there's all of these little things that happen along the way that the smart person sometimes would say, I'm done, right? There's got to be an easier way. But that grit, that definition of grit that drives us to the finish line is really what we're trying to foster as therapists for those babies, knowing how beneficial breastfeeding can be and knowing we need a mom who's driven and healthy and also thriving from a physical, mental, emotional place. And how do we support her? So grit just itself is something that we need as parents, and we need to be able to drive us towards our goals. And so haven't finished it, but so applicable. Grit and the power of passion and perseverance. What role does mom want to play? So if breastfeeding is the goal, what does she want to do now? So is she talked into it? Was it because the neonatologist pulled her aside and said, hey, breast milk is really good for our babies, and we need it in order to make sure that we're reducing infection, neck, other issues that this baby could potentially have? Was this mom never interested in breastfeeding, or was it her only dream to be able to put that baby to breast and maybe never offer a bottle? And how does that vary along the NICU journey? Does she fear putting that baby to breast because they are so compromised? How do we as an interdisciplinary team support each mom and baby on their journey? Because they are both at the center of care. So it's important to remind ourselves kind of what a length of stay could look like. I started our outpatient feeding clinic about 8 years ago because as a NICU therapist, I felt like we were just kind of coasting along in the NICU, it felt like, prior to some new feeding practices. And then all of a sudden it was like, all right, PO ad lib. Oh, okay, cool. Go home. Go home. You're good. You've gained weight for 24, 48 hours sometimes. You got this. Sometimes it would happen on a weekend and I'd show up on Monday. Really? They were a terrible feeder on Friday. Okay, that's great. We were sending babies home with entry-level skills. And I think to a certain degree, sometimes we still do have that feeling. So what happens during our NICU time can really impact the overall success, and how do we spend that time towards practice and education and driving us in those short-term goals that are going to help us get to that long-term goal of a healthy feeding baby and mom. So the average length of stay, 93 days for a baby who's born before 27 weeks. The average being 8 days. So we have our late preterms that sometimes aren't there as long, but still 2 weeks is a long time. We have to appreciate the mom's time that is also spent in the NICU. Sometimes her maternity leave is gone. Sometimes she's been pumping and pumping for months on end and still not able to put that baby to breast because they're too compromised. How do we maximize on that length of stay? Environmental factors for that NICU baby. What does your NICU look like? Do you cringe when you walk in if you haven't been there for a couple of weeks because you're on vacation and all of a sudden that sound that you were used to feels very aggressive because you're wondering to yourself, how do these little babies stay in here for 24 hours? What's the nurse's station like? Does everybody congregate there and hear everybody's conversation? And is there a bed space for a certain really sick NICU baby that's very close by? And does that mom hear everything we say? Do we offer privacy? Is there a time to be with that mom when she's holding her baby so that we're offering her that encouragement and that positive reinforcement of learning? Or do you walk away when mom says she's ready to do skin to skin or nuzzle or attempt to breastfeed because we feel like that's a time for privacy, for that mom, and maybe it is, but maybe it's a time of vulnerability that she needs you present to say, this is how you hold a baby. Look how that baby is happy right now in your arms. Look at the communication they're giving you by gazing in your eyes. Look how they quickly fall asleep in your hold. We need to build those positive experiences, lessen the negative, because not only are we creating an environment for that baby, we're creating an environment for the parent. So those positive experiences begin with skin to skin and containment in that calm, supportive environment. And they build to breast milk as oral care. We guide hand to mouth or see it happen spontaneously for those babies who are trying to be self-soothers. And then we guide mouth to breast. We do nurturing positive touch, nuzzling that will lead to that non-nutritive suckling that then eventually leads to the nutritive latch. So we talked about environment. We talked about the people that were included in this environment, but what's the occupation? So the job of this infant is to thrive. It's to gain well, adequate volumes to gain weight without signs of stress. How many times have we said that as feeding therapists? And the role of that parent is to care for, nurture, protect, understand, advocate, on and on and on. And with first-time parents or even subsequent children, that call of duty is real, and they're doing their best to try to figure out how to best do that. But have we sent subliminal messages that said when that mom walks in, everybody walks away? Or do we come and greet her and say, oh my gosh, you're here. Your baby is going to be so excited to be in your arms. We have to support that thriving baby when we support the person in charge as the primary caregiver and the nurture. And I must say, this has to include dads too. Sometimes they don't know their role. So I know I have a focus today on breastfeeding and on that mom, but we're supporting all the people who have a desire and a burning interest to care for that baby. So the developmental expectations of oral feeding. First, we think of non-nutritive breastfeeding, and that's usually starting between 31 and 32 weeks. To true breastfeeding, 32, breastfeeding, 33 to 34, and then feeding plan is the long-term goal. Sometimes our babies are discharging by 35, 36 weeks, right? Is this happening at time of discharge, or is there a need for continuity of care in the outpatient setting? So again, a little bit about our feeding practice is I really thought I was starting an outpatient feeding clinic for our NICU graduates. I really did. That was my goal. We needed more support post-discharge. And what I discovered was probably 60 to 75% of my clients are actually term babies. Even term babies don't breastfeed well or feed well sometimes, and they're supposed to know how to do it, right? So when we take a baby who has legitimate excuses to not be here yet, to not know how to do these things yet, and we ask them to know how to do this well, we have to really kind of look deeper to say, is this a realistic goal, or do I have an ethical reason to continue to support your development? We have to give grace to the issue. So as we're thinking about a baby who the long-term goal is to breastfeed, is it realistic for that mom to be in the NICU 24 hours a day or 8 feedings a day? Having your baby in the NICU isn't the plan. And so we have things like infant-driven feeding and scoring that is inclusive of parents, so that we have terminology that isn't specific to the NICU worker, the nurse, the doctor that can speak in medical terms with the therapist and the respiratory therapist. We have terms that we can say with parents' presence, and they know what we're talking about. So when we have a mom who says, yes, I want to breastfeed, or yes, I'll pump, maybe it was her idea, maybe it was ours, but they've put in a lot of grit. We need to give them a breastfeeding window to see if that grit and that bonding gets to have some foundational knowledge of seeing what that baby can do. But beyond that breastfeeding window, we need to afford practice experiences. It's not meant to just be a 24, 48, or 72-hour window. It's meant to build some confidence that they're able to continue on as we go on demand feedings or PO ed lib or readiness feedings, whatever you want to call it in your NICU. So when a mom is pumping, make sure that she's got her supplies right there in the NICU, that she can do that right by that baby, so that if she did a nuzzle experience, that she's able to follow that with a pump session. Make sure that she has a plan for home. If there are bottles that have been purchased already through a baby shower, let's talk through it, right? Do we have a bottle that we have to use? Or can we give it the good old trial and error with education to say, let's see how your baby works with this bottle, and let's see what kind of feedback they provide to us. And then we together as a team, parents and feeding therapists, get to decide what's the best feeding avenue for your baby. We must afford the adaptations to achieve the goal, with the appreciation that the unique qualities of each person, environment, and occupation must be afforded. So maybe mom doesn't have full use of both arms. Maybe our environment is going home to grandparents or foster parents. All of these things are things that we think about from a discharge education standpoint, but let's not wait until the time of discharge. Let's make sure that we're considering that this is a baby who is a twin or a triplet or very first baby, history of IVF and years of trying, with a lot of anxiety and going home. How do we reduce anxiety? As we talk them through it and give them practice so they know that this job is achievable. So feeding it as a dynamic task, I know you all know well, suck, swallow, and yeah, we got to go ahead and breathe there. In the development of maturation, it really matters. So if we have a kiddo who still just sucks to calm and forgets there's a swallow and a breathe that needs to happen, we need to consider, is mom to have a full breast when that baby doesn't know how to coordinate the swallow and breathe pattern? In our pre-feeding skills, we need to know who woke who. So from a readiness scoring, if that's what your practice uses, we say, gosh, you're awesome. You woke up prior to your feeding. And we all kind of know to a certain degree, those are the kids that are knocking on home's door. If they woke up and they said, hey, get over here, why are you not feeding me? The loud babies are oftentimes the babies that are close to discharge. But we also have the population that goes home, and maybe this is more of the majority of the population in your NICU, that are going home because they are able to arouse, sustain alertness, work on the pacifier, and finish the feeding, but with the support of you as the feeding clinician or the parent as the feeder, to make sure that you're offering them the adaptations. Potentially it's a swaddle, potentially it's sideline position to sustain that alertness to finish a full intake volume. But we have to consider, if we woke up a baby and we say, hey, it's time to eat. I always think about my teenagers here. And if I wake them up and I say, hey, it's time to go, what do I want to do? What do they want to do? You want to hit the snooze button. You want to go back to sleep oftentimes. Some of my children are hitting the ground running, but not most anymore, especially as they get older. And babies can have the same sort of response. If you woke them and then you put them over with that coziest person in the entire world, AKA mom, what's going to happen? And is that a compromised breastfeeding situation, or is that just general understanding that you have a baby who's put to breast with the coziest person in the entire world? Are they going to fall asleep? And sometimes in those situations, we get to talk through that with mom and say, if they're kind of awake, mostly cozy, looking kind of tired, what happens if I put them in a swaddle hold and put them in sideline? Do they go, hey, oh, okay, hey, we're going to eat now, versus skin to skin in a nuzzling position? Just questions to ask, because it's not necessarily indicative of if breastfeeding is going to work well or not, but we have to give it those lenses to say, how well do we anticipate this to go? And if that baby woke up first demanding feedings, telling you that's when breastfeeding is ready to take off. So the preemie and the full-term baby, lots of differences. That preemie may have respiratory distress and breathing complications. Suck, swallow, breathe. That's a factor. At 35 weeks, a baby's brain still needs to grow 50%. Think of the exhaustion that needs to happen. The need to sleep trumps the need of hunger in many of these cases, which is why we're really protective of sleep. And we want that baby to eat potentially every 3 hours. Potentially it's on demand, and that encompasses more of a 2 to 3 or even 4 hour window. But we know that that brain maturation is still occurring. The baby of a preterm may not be able to have enough body fat to regulate temperature. So our late preterm population gets a lot of attention because if they're noticing temp drops, what's going to happen next? Usually feeding is going to be compromised. Or if we take a baby out of the isolette, sometimes the feeding takes a hit because they're now working a little bit more on temperature. All of these are factors that contribute to the feeding. Maybe they have problems feeding because they're just not fully equipped to suck, swallow, and breathe. Maybe it's because of early development, and maybe it's because of other medical issues. So when we talk about infant intake volumes, I feel like this is another kind of hot topic. So we will sometimes see late preterms within 24, 48 hours of delivery to help parents support that infant through early feeding skills, and also to be a clinician present to say, is this baby going to do well at home, or are they giving us enough clinical signs that require a NICU admission? So one of the most frustrating things I think as a human being to hear is, great, you did that well. I'm going to ask you to do a little bit more, right? Like, wait, I just accomplished that goal. Can we just stay here for a minute? No, I'm going to need you to do more. So we want to simplify through education how a parent can understand why a baby needs what they need. And so we're giving an approximation of intake needs, and we know it's a moving target, especially during the first days and weeks of life. But a way that we can kind of simplify this through the lens of the clinician that knows math and has a dietitian at their fingertips is by understanding that a 5-pound baby needs around 50 milliliters. I'm going to show you on our next screen. A 6-pound baby needs closer to 60, 7-pound baby 70, and I'll show you that correlation here in a second. But we're also giving them a way that they can track it. So you see in a little example that we use here at our hospital where we're tracking the start of the feeding. Did we breast? Did we bottle? What was the baby's mood? Because it's very indicative of whether or not they actually breastfed or not. A sleepy baby didn't eat. The baby with a consistent suck swallow at breast got food, but the baby that just nuzzled or offered no effort, they didn't. That's not feeding. That's just being present at breast. So did we need to supplement that feeding? And were we able to use mom's milk? Cool, right? They still got breast milk. And if we didn't have enough of mom's milk, there's where we need to kind of start to see it through the lens of this is our room for improvement category if long-term goal is to breastfeed. It gives us the math that helps us to understand the bigger picture. And if we needed to give that baby a supplement, we need to pump. We need to protect supply and demand. So this is the screen that I really wanted everybody to see, because I got to tell you, I spent a lot of years as a clinician before I got the aha moment of how you can calculate how much a baby needs based upon their weight. So that calculation is here on the screen for you. But as you scroll through, I just want you to appreciate as you go down the grid, the 3-pound baby needs 32 milliliters. Again, based upon approximation and feedings every 3 hours or 8 times a day. Continue to move through the line. The 8-pound baby needs 81 mils. The 10-pound baby needs 108. I love sharing this information, not just with parents, but with nurses who've had to use that calculator for years and years. Because again, the aha moment for me was real. And I was like, oh my goodness, this simplifies it so much. But as a baby who was in the NICU, who had their calculations given to them on the daily of, you know what, you moved up to 43 today. Cool. Sometimes the parent was like, I just was able to start to get them in the 30s range. You moved it up again. It's nice to know that as they have them at home, that it is going to be on-demand feeding. It is going to have fluctuation, but we get to say the 5-pound baby needs 50-ish based upon feeding 8 times a day. So if they took a feeding where maybe they got 30 or 35, no big deal, because you took 60 the one before that. And it all starts to just to equate to how much volume did you get in the last 24 hours in order to gain weight and grow. So the breastfeeding algorithm, this is reprinted with permission with IDF, but it's definitely been a source of conversations because we do practice IDF at our hospital. And how do you interpret the breastfeeding algorithm? Even if you aren't using IDF at your hospital, you potentially have a way to at least gauge how much do you think a baby got at breast. One of the things that I really wanted to ensure understanding before we started using it at our hospital is the appreciation for how much does mom bring to the table. Certainly, you can't assume a baby to nurse for 11 to 15 minutes and need only partial volume if that mom is producing 10 mils per pump, right? So you see on the screen per nursing discretion. We must make sure that we're hearing audible swallows, and we must have an appreciation for how much milk that mom brings to the table. So in this light, I kind of was doing just deep thinking of how do I give this the knowledge that it really deserves. And as feeding therapists, we would not be okay with someone else, not a clinician, showing up with a bottle that we didn't know anything about, right? That maybe the bottle was fast, maybe it was slow, maybe it had a nice long elongated nipple, maybe it was a little bit more flat and rounded. Maybe it started really fast, but then the bottle changed throughout the feeding. That would drive us crazy, right? So when we are trying to build this bridge for successful breastfeeding, we want to know more about mom because that is our tool to feed the baby. We need to understand what she brings to the table. Is all the milk on the right? Is it on the left? Do we have flat anatomy? Do we have elongated anatomy? What's her milk ejection reflex, which is what we call letdown in slang terms? Is it right at the beginning, or does this mom get 2 ounces every time she pumps for a baby who needs 2 ounces every time they feed? But it takes her 30 minutes of pumping with hand expression, with a slow trickle in order to get that yield. If that's the case, is this current practice of the algorithm applicable? Maybe not, right? Maybe not. So if we're saying a baby is gaining or not gaining, I don't know about you, but I think as a mom who breastfed, I constantly was worried about weight gaining being my fault. If it didn't go well, I did something wrong. We are increasing that tenfold with the NICU mom of if they didn't gain weight, is it my fault? We need to give that mom and that baby as much knowledge as we can to make sure no one has regrets. So if we don't bring enough milk to the table, we're going to need more milk. Is that going to be through the NG tube? Is it going to be through the bottle for the more mature baby post breastfeeding? I don't know, but it's something that we need to be considering when we're thinking about using an algorithm. So this slide can be a little bit redundant, but worth sharing. The reason why we breastfeed is for that breast milk, human milk for human babies. Again, formula shortage right now. The amount of guilt that parents are feeling in choosing to use formula or needing to use formula is so strong. It's beyond what we think needs to happen or what that mom wants to do. The benefits of breast milk are undeniable. The milk expression, again, we're talking about how do we support mom? How do we get that milk to come out? We need to optimize her milk supply. So where I worry sometimes when we're working with moms is we're trying to give them empathy. And this is a valuable thing to be able to give to a mom who's experienced a traumatic birth and now a NICU baby. And it's important to recognize that she's stressed, that she's overwhelmed, that she is exhausted and potentially running back and forth between home and the NICU. But it is not our place to tell her to sleep through the night. It is not good practice to take that baby, if they were still late preterm, on the floor and put them in the nursery because we noticed a mom to be really tired. It is our place to say, you look exhausted. You need to take care of yourself. What are plan Bs that we can offer to this situation so that you're taking care of yourself? But I think we empower women when we tell them what normal looks like, what the breast oftentimes needs in order to build an adequate supply, because those first hours and days of milk expression and prolactin levels really do give us some indications for long-term success of milk supply. So in order to optimize milk supply, moms must pump every 2 to 3 hours. They have a goal to pump 8 to 10 times a day. So if you've told her 5, you told her your empathetic response. But what we have to look at is how nature intended this to go. And full-term babies eat 10 to 14 times a day. And they do that for their first days and even weeks of life. So when we've separated mom and baby and we tell her 5 to 6, you have to give that the light that it deserves. Do your best. If you only get 5 to 6, I understand because you're doing your best and you're compromised. But please understand, if you are struggling with milk supply, this is the all-in mentality of how this can look. So hand expression certainly can work. We definitely fall towards hand expression when pumping is not working, and definitely for early milk supply. With our goal milk volume for each baby, we need 24 to 30 ounces per day per baby. That's a lot, right? Especially for a 3-pound baby. The reason why we say that for moms is because we know milk expression can be really high and manageable if we can really let prolactin know, hey, we need you here at the beginning. We can cue that response of milk supply that's going to keep going. And then we can start to wean down. Now, if this mom has a history of oversupply, that also needs delicate hands. We need to talk through that. Okay, who are you? We don't know who you are if you've not had any babies. We don't know how your body responds to delivering a baby. Does prolactin spike, or do you always struggle with low milk supply? So when we're giving them a goal milk volume, we're trying to understand the mom who's making just enough, the mom who's making enough for what we would consider to be a full-term baby, just why that volume is there. Or is it a mom who's making enough milk to feed the entire nursery, but she gets such accolades when she walks in that she continues to pump 10 ounces 8 times a day. And now she's got clogs and mastitis and doesn't know what to do with all this milk that's coming out of her ears. We need to make sure that we're optimizing them during that average length of stay of 8 in the NICU, so that we're not sending them home with low milk supply, oversupply, and a volume that potentially is just enough for a baby who's not working as hard as maybe what we need them to in order to get that full milk expression. So now we get to move towards latch strategies. Hopefully this can be helpful for you all. Again, this is something that really drove me as a clinician to make sure that I was lactation certified. I needed to be able to offer information beyond personal experience. And so I encourage you, if that burns in you, to, if potentially you are finding you have enhanced knowledge on infants, on readiness, on non-nutritive suck and bottle feeding skills, you need to look deeper. Because if we're using breastfeeding as plan A, as the model of care that's most desirable to be achieved, you have to know how the breast works. So we're thinking about improving that latch for not only feeding efficiency of mom, feeding efficiency for baby, but for reduced pain of mom. So how do we achieve a proper latch? The first thing that we need to consider is starting that baby nose to nipple. This will help to ensure that when the baby opens up their mouth, that the nipple will be at the roof of the mouth. The goal of this starting position is to achieve what we know to be an asymmetrical latch, where the nipple hits the palate, the roof of the mouth. What you'll see in this latch technique is that the infant will have more of the areola covered near the chin in comparison to the amount that's covered near the nose. This allows the tongue to achieve central grooving underneath the nipple, and it triggers the infant suck reflex, palatal pressure, suck reflex, due to the sensation on the roof of the mouth. We must wait for the infant to demonstrate a wide mouth opening. So one of the most common mistakes that we recognize when a mom is describing a painful latch is mouth to nipple alignment and a hand that is on the back of a baby's head, restricting the head lag, that nod response. So we want to wait until that baby is truly ready, and that's not with the yawn, that's with the root reflex. And it may require a little bit of patience, but when they're hungry and they're rooting, that readiness, that root response is so much more. Do not allow your babies to latch with a narrow mouth, because a mom oftentimes will say, it's okay, because they latched, right? But what they're feeling on the inside is, whew, this hurts, but okay, I can do this. Because remember, Call of Duty, this is our kind of intrinsic response, is to care for baby first and think of ourselves as secondary. The idea of a pain in latch can be graded in our pain scoring. If we have maternal pain, I want to know the number. Is it a 10? Are you crying? Or is it, okay, this is different. This is a new activity. I feel this. I generally will tell moms a 0 to 3 on that pain scale of 0 to 10 is acceptable. It's kind of okay. And if it gets worse, please let me know, right? Because there is a discomfort that is associated with those early latch experiences, in my opinion. But when it's 3 out of 10 or less, from a practitioner standpoint, we say time for intervention. We need repositioning, potentially we need pain medication. If you have a mom taking pain medication to breastfeed her baby, that's a problem. We need to make sure that we're identifying the issues with the latch that's causing the pain. So number 3, once the wide opening is seen, mom should quickly bring the infant to the breast, facilitating that nice deep latch. The chin should touch the breast tissue. And once the baby is latched, that jaw angle should be greater than 100 degrees with the goal of 140 degrees. This mom needs to offer some firm postural support if the latch is in question. We won't just line a baby up until that proper latch is more consistent, and then it becomes routine, and then it becomes less effort for the caregiver. So in this picture, you see this sweet baby boy latching with his mama. He had a history upon our meeting of very narrow latch experiences. And so one of the techniques that we were considering for this sweet baby was making sure that we had postural alignment. So you'll see where the kind of nipple hits, mom is supporting breast and mom is supporting baby. That palm to shoulders hold allows that forearm to be parallel to the spine and to hold that baby deeply against her torso. So in this video that you just saw, hopefully you got to see that beautiful head lag. The way that in that split second, mom was able to notice head lag, nod response, and then guided that baby into a nice deep latch. She kept her hand on the breast, and in doing so, she offered some postural support by wedging the breast tissue in a shape that matches that baby's oral anatomy. By doing so, we offer, and I always put this out here because I think it's a real easy thing for moms to grasp. It's a hamburger, not a taco. So that hand needs to be in a C shape with her thumb parallel to the upper lip line of the baby. So we're offering, again, that wedge shape of breast that helps that baby to use sensory motor skills to find mom. And in doing so, we're also offering that nipple to the roof of the mouth for the sensory motor response. Things to consider in these special challenges. Did this fit? Does mom have inverted nipples? Does she need help with elongation? And how do we do that with her? Are the infant's oral movements concerning? Do you notice a lip tie, a tongue tie, the intact frenulum dilemma, right? When do we do interventions for this? I always will pair with the pediatrician's expertise to say, one, is it functional? And by functional, I say, is this baby gaining good weight? And is this mom pain-free and latch? Because if the answer is yes to both of those things, that's functional. If one of two or both of these things are impaired, what other options do we have? Is there something that you actually see? Do you see a restriction of range of motion? Or are you, I don't really know what to look for. And it's okay to be honest about that because we have practitioners like ENTs that are the experts in a revision. And so when we've neutralized all the other complaints for this to be a painful latch, we've looked at postural support, we've looked at alignment, we've addressed milk supply to make sure that it's not a non-nutritive suck causing this issue, but there is milk flow and mom is still really painful. What we need to afford is another opinion, an ENT consult that will potentially be able to complete a revision based upon the findings of a lactation consult, a feeding consult that says, first, is this functional? So that we know the revision is justified. The idea of a nipple shield can be really supportive for a baby who doesn't match well with their mom. Potentially it's because they lack tongue elongation and central grooving. Potentially it's because mom lacks an elongated nipple. I will tell you it works best for a mom who has really good milk supply, because there is kind of another layer that we're thinking about that that baby now needs to pull the milk through. But if she's got a good milk supply and she's able to offer a little bit of hand expression, that nipple shield essentially becomes a reservoir for her beautiful milk supply and a one-stop shop where that baby is able to find mom, create the central grooving around that shield, and build a bridge to what we hope to find later as long-term breastfeeding without use of the nipple shield. I will tell you with the nipple shield, it's proceed with caution. If we use it in the first days of mom's lactation, it sometimes can be more of a non-nutritive suck, so we must hear swallows with use. And please do not use a nipple shield unless you have a lactation consult on hand to ensure mom is producing milk and knows how to maximize on that milk production with the nipple shield use. So next thing we want to talk about is the postural support of both baby and breast. So a lot of times, again, we're kind of thought a baby should just be held in cradle hold and find mom, right? So my early days of being CLC certified was all rainbows. Babies are going to crawl up your chest. They're going to find you. They know there's a target there, right? I think this is beautiful for a lot of people. I happen to not be one of those people that it was beautiful like that for. So there was some guiding involved. And as a mom, knowing what to do and how to support my baby, that helped my babies to breastfeed. And I like to be able to afford the same idea to our clinicians and to our parents, and to allow these moms to feel really enhanced in their education, that they know how to guide their baby into a deep latch. So we will often use cross cradle and football hold to support the neck and shoulders, as seen in these pictures. So here we have some more pictures of that cross cradle hold. Notice it's the same, essentially. It's forearm to spine, it's palm to shoulders. It's one hand on breast, one hand on baby. In the hand that's on breast, it's supporting the breast by creating a wedge position. That hand does not have to stay on breast if the baby is able to sustain a latch at their breast on their own. So really, we might be guiding for the latch, staying there for 30 seconds, and then allowing the baby to quote unquote find the grip, right? And then we can take the hand off. We can bring the hand back if we're noting areas of firmness in the breast tissue that could benefit from massage to reduce the incidence of clogs. But the idea is we're guiding there first, and we're saying, how you doing, baby? Do you fit here? Are you able to find a nice deep latch, or do you need my help? Because I can help you. I know how to work my anatomy in order to enhance milk flow or inhibit it if that's necessary. But the hold, essentially, like I said, it's the same. It's one hand on baby, one hand on breast. So some special challenges that we'll notice and recognize to milk supply are: one, did mom have a traumatic birth? If she is compromised, there is a strong chance that her milk supply might have been compromised. If she has low milk supply, is it related to gestational diabetes, hypertension, blood transfusion? We are not going to rewrite her story. Her OB was able to guide her through her story and her journey to help her to deliver this baby in the best means that they know how. So as I reflect on this with moms, what I take ownership in is I am not her clinician. I oftentimes, when I'm seeing my babies in feeding clinic, do not know her past medical history beyond what she's shared with me. But what I can do is talk to her, and I can empathize with her that things have been traumatic and that she's working on different factors. And I can encourage her to go back to her OB, her practitioner, and ask some really good questions and thoughtful questions as to, do you think this is going to get better? Because if you have complications, as mentioned in this slide, there is a risk that you might have low milk supply. If it's your first baby, sometimes there's a curve to that. What's the time management strategy for family life balance? Is this a mom who has to go back to work in 4 weeks? Is this a mom who she and her husband are both off for 16 weeks? There's a difference in how we can manage breastfeeding, pumping, triple feeding when there is support at home. Do we have a grandparent who's willing? I think so often, so many of us are not willing to ask for support. And sometimes just with a call, we can gain that support. So we need to know that the mom's doctor is still supporting in her goal to breastfeed. So that baby is out, but her breast health still is likely to need of management. And I had a patient just recently ask me in frustration, because she was really frustrated on her need of formula as supplement. Her milk supply was really low, and subsequently latch was not great. Baby was aggressive, wanted more, bucking, arching, pulling, and then fatigue, right? And then she would have to transition to pump, bottle a supplement, triple feeding. And she's really down on herself. And she said, 100 years ago, what did they do? Like, everybody could breastfeed. Why can't I breastfeed? And I think the thing that we have to really recognize is 100 years ago, this particular mom might not have been able to deliver a baby. She had a failed induction. She had vacuum assist attempts at vaginal delivery, all to end in a C-section and a blood transfusion. This mom 100 years ago, I don't know what would have happened, but I have some guesses. And so for her milk supply to be low, we have to empathize with. This mom is still recovering from a traumatic delivery. Her body is recovering, and therefore prolactin, milk supply, is going to take some time. So as we have kind of shifted in society to breastfeeding to be the norm, the goal for all people, there's a certain level of judgment that comes when a mom isn't breastfeeding. And it makes me crazy to think about us judging other women when we don't know what they've put in, what grit and determination they've given to give this baby the best means of nutrition possible. What we don't know is what's going on behind the scenes. And we know that that's with all cases in life. So we're building habits. We're developmentally that understanding of norms where NICU moms do have extra layers of stress from what the baby brings to the table, what they bring to the table, the environment, and the job of feeding. We need to know where they are at and where are they going, because willpower, their determination, their grit, it will improve as we empower and foster that bonding and relationship with mom and baby. So our closing thoughts today, our checklist to successful breastfeeding is we have to know the goal, and we have to afford the education that goes with that goal. So we all will say we want a healthy, thriving, fed baby, but we need to say, and the healthy, thriving, balanced mom. We want both. It's not all about the baby. It is about mom and baby and that long-term goal. We need to know that the intake goal is evolving. And so what they needed at 3 pounds is not going to be what they need at 5 pounds or 6 pounds when it's time to discharge. We need to know output, intake and output. How do they balance? How much milk is mom bringing to the table? And how do we decide how much was the rate of milk transfer while they were there together? The timeline with the trajectory of the intake and growth, the rate of milk transfer, so important. I will tell babies who I see in their first days of life in the feeding clinic that our goal is to return to birth weight by 2 weeks of life. And that's a shared goal that I hear with most pediatricians. If we're not there, you don't fail. You don't have to turn your baby back in, but we need to know what's going on. Why is this hard? What other means of nutritional supplement have we needed to do to make this work? And then that ongoing goal, and this is usually coming already at the time of discharge for our NICU kids, is to continue to gain around an ounce a day or 5 to 7 ounces a week. Are we doing it excessively? Are we doing it in an under way? And is it okay to have some flexibility? Yes, it is. But if we have a baby who stereotypically took 3 ounces 8 times a day, but is a 6-pound baby who's growing at an exceptional rate, and now parents are very worried because they don't seem to want to wake up every 3 hours and eat. We need to give them the understanding that a 6-pound baby, remember, needs 60-ish 8 times a day. And so if they started taking 3 ounces, that's cool, but that can't become the new expectation, right? So PO readiness, who woke who? This impacts breastfeeding. So the late preterm baby who made it home instead of going to the NICU, who woke who is a big indicator as to how breastfeeding is going to go. It's also an indication for helping moms to decide, do I want to breastfeed at this moment or do I want to bottle feed at this moment? How reliable is this baby in their participation of feeding? And we use infant-driven feeding to optimize the feedings with the decreased amount of stress by using caregiver rateability that can be shared with the parents, with the nurse, with the doctor, with the feeding therapist, and on so we support the goal. We talk about the infant feeding development. Where are they at? Are they still a 32-weeker, or are they giving us those suck responses of a 34-weeker? We are talking all day long. What's mom's practice and how is she supporting the NICU? Do we have her come in and just say, did you bring us milk? Or do we say, hey, how's it going? You know, how much you must have worked really hard to get this, and offer her the encouragement that she needs to give her those small wins with the short-term goals that are going to build into the long-term goals. Break it down for her so that she is intrinsically motivated to stay in for the long haul. And as we complete the goal, we have to recognize that the way that baby is feeding at the time in the NICU isn't always the long-term goal. We have to afford the resources that are necessary for her to get help, to ask questions without feeling like she is saying, I don't know how to care for my baby, that she's just getting the reinforcement of learning and the progression of flow rate that sometimes is needed when we're transitioning bottle from time in the NICU to time at home. We empower her. We enhance intuition. We encourage safe feedings for the infant. Also, we're thinking about allowing the modifications for home life. So in this last slide here, you'll see our list of references is pretty comprehensive. Please let me know if there's anything I can look into deeper for you, with you, so that we can learn together. And now we can open everything up for questions and discussion. Thank you.
Thanks, Elisa. What a great wealth of information. I know somebody said the reference list was hard to read. When we print it, when it comes in the attachments in the online, when the whole webinar is posted, it'll be easier and hopefully you can read it a little bit better. It looks small here, as I can tell on screen. So, so much information. And can you specifically talk a little bit more about who gets referred to your developmental follow-up clinic, or your, I'm sorry, not developmental follow-up clinic, but your breastfeeding clinic, and how does that work? If does every NICU baby go, or who gets referred there?
So yeah, it's all pediatrician referral. So the diagnosis is infant feeding difficulty. So we don't do blanket orders. We do it on who has difficulty and who also has interest in continuing education and therapeutic intervention from an outpatient standpoint, because some families don't want to, they want to go home and they want to figure it out, and that's to be respected too. So it's not a flat referral, it's more on as needed. And I will say, in the 8 years that we've been open, we haven't marketed at all. We've kind of just gone word of mouth of, we're here if you need us, and it's blown up just in that sense, because we know that even that full-term baby who isn't gaining weight in the pediatrician's office, it's sometimes a quick visit. And so now we have pediatricians in our area who recognize that they're trying to go over a lot of things systemic wise, and they will refer to the experts to be able to guide that course. So we do see a lot of our late preterm graduates, kiddos that potentially would have been borderline NICU admission, but ended up going home, because those babies are just kind of surface level feeding, and families appreciate the feedback, the weight checks, the short-term goals that are happening potentially twice a week, where we're checking in to say, have you accomplished this? Okay, now we're ready for this. If that answers your question, hope it does.
Yes, thank you. So do you ever recommend supplements to increase milk supply? And if so, when or what?
So supplements we'll kind of talk about. They're not FDA regulated, and so I always will share that. But a big important piece for our practice is we're occupational therapists that are also lactation consultants, but we don't open a chart on mom. So when we talk about supplements for mom becomes the patient. So that's not a line I'm willing to cross. So we'll say, there are different types of supplements that some women will take, but I want you to talk to your practitioner about it. I think that there's definite wisdom that you can find in using your resources to say what's worked best for other women with my past medical history. But there are also some supplements that do not do well with other medications with past medical history. And so that's where moms need to kind of be able to be their own best advocate, to do their homework, to say what's going to work and what's not going to work.
Yeah, so if maybe for a lot of other people, if you can explain that a little further, because as someone who previously wore a couple different hats in the NICU too, you're employed as the occupational therapist, but you're also an IBCLC. Do you also have IBLCs who come on, and or how does that work, juggling that?
We do.
Roles?
Yeah, so we absolutely do. We have a great lactation team at our hospital as well. So I think it's kind of in that same thought. I think a lot of people can understand how like potentially OT and speech collaborate on feeding, and how OT and PT can collaborate on positioning. It's very similar. Because I think we're both bringing to the table a different potentially focus, where our focus is on the infant feeding development, especially when we're talking about that underdevelopment of progression, where the lactation consultants that we have oftentimes are labor and delivery nurses, or they worked in postpartum for years, and that's kind of been their background of training. So they have that unique quality to them as well. So it's a lot of collaboration, making sure that we're not stepping on each other's toes, but just kind of enhancing each other's knowledge as we guide that baby through the support. But in the late preterm environment, especially, it's really fun to be able to kind of offer them that additional support. So we kind of get the baby started, making sure they understand the developmental outcomes, and then lactation will like, now let's talk through your pump. Let's see what flange size fits you best. Let's talk about how we can make this work best for you, and problem solve through that.
Great, thank you. How about nipple shields? Let's talk a little bit about that. Can you speak, somebody just wants you to speak more to that, but when to and when to stop, and also kind of piggybacking with that past question, like, so as an OT, can you recommend them, or does then it have to come from LC? So
no, so we absolutely will recommend a nipple shield when those puzzle parts don't fit adequately. Sometimes we see it kind of in this like lost excessive root response that a baby will present with, like they can't find you, right? They don't know where the tongue goes, where do my lips go? The soft tissue I'm supposed to form into a shape all by myself. Who's going to help me with this? So the nipple shield can kind of create this bridge of, this is where your mouth goes, right? Because we have that firmness of nipple that kind of guides them. And then again, it's a lot of parent knowledge to know what we're looking for. So they have to recognize what the non-nutritive suckle looks like, because it can be a pacifier attached to a breast. But when the suckle transitions into suck, swallow, breathe, we're hearing the swallow. We're seeing the swallow. The baby's nutritive in its latch, because you can hear him go goom, goom, goom as they go. And so sometimes it's mom helping that with that flow. They're using hand expression to kind of get things started. So obviously first goal is bare breast. We want to start at bare breast. If that doesn't work, what can plan B look like? It's kind of just another thing that we can keep in the toolbox, but it happens to be one of those things that if you don't understand nutritive versus non-nutritive latch, that's where the wool can go over a parent's eyes. And if they use it too soon without knowledge of what nutritive used to look like, you can see really long feedings with a high frequency, with the baby that only calms because they're attached to a nipple shield and having a mom hold them, and then they don't gain good weight. So it needs a lot of intervention from someone who's skilled in the area of lactation assessment, feeding assessment, to make sure that it is a nutritive suck. And then we try to wean off of them as quickly as possible, because they're a gift until they're not. Then they're a nuisance, and I don't want that anymore.
The goal is breastfeeding with breast and not the nipple shield, but
correct.
Great. I love the way this question is worded, because it's breastfeeding opportunities. How do you navigate breastfeeding opportunities around enteral feeds? And that question alone answers some of the question, right? Because we want to provide positive feeding experiences, but if you can address that specifically from your point of view, that'd be great.
So they are opportunities. I love that, because we're thinking about positive practice experiences with everything that we do. So I think it's when we are going to the bedside and talking about NICU specific babies, we're kind of there while mom's doing the diaper change and offering the pacifier and talking to the baby, and the baby's looking up, and everybody's just kind of having this little conversation with each other. But then as we sit down, we say, hey, mom, what do you want to do? You want to put him to breast? Have you pumped recently? Yeah, I want to. Let's just see how it goes. Well, then again, we talk through the postural support of, what does this look like? How do we get it started? Because I love it when babies make me liars, right? You think they're not going to do a thing, and then you line them up and they're like, hey, mom, no kidding. You make all this milk and I can do this all by myself. So we don't know what they're going to do until we give them the opportunity to do it. So it's that paired knowledge of developmental expectation, but giving them an opportunity. And by having that protected milk supply, I often will say it's an offer you can't refuse when you're a baby, as long as they can sustain alertness. If we have a mom who can make enough milk and she knows how to make those puzzle parts fit together, that baby essentially is made an offer that they can't refuse. And so you'll see that suck, swallow, breathe take off, but then we get to say, how long can they stay in that nutritive suck pattern? And if they're running out of endurance, age appropriate or medically appropriate given all you've been through. And then we get to say, now it's time to snuggle with your mom because you did an awesome job. So remaining feedings go in through the NG2 versus now they came off and they kind of went, oh, I don't even know what happened back there, but you see them burp, re-alert, and a mom potentially is ready to offer a supplement because she knows that she might not make enough. She might not be able to make that offer that this kiddo can't refuse it. So maybe they got a tasting, but they need more volume. And that potentially can be, for that more mature kiddo, a time where bottle is also happening at the same feeding.
Thank you. I know we have so many more questions. As you all can see, this is a huge topic. Elisa, you are a wealth of information. I want to let everyone know, remind you that the questions that were not answered, we are going to have Elisa answer them. They will be on our website. All right. And then also, you will receive an email within 24 hours for directions on how to get your eval and your links and your CEUs. And I to end this with all these questions. So our formal part of the webinar is over, but there are obviously a lot of questions about breastfeeding in the NICU. And I just wanted to let everyone know that Dr. Brown's medical, obviously we do have infant-driven feeding, but since breastfeeding is one of the biggest questions people have, we are developing a breastfeeding module that is going to be added to IDF, and it will be coming soon in the next couple of months. And you will be receiving some newsletters, you will receive emails from account managers, but it is coming soon. And we are very excited that this will be an addition to the infant-driven feeding program. So that'll be coming soon. You'll all get more information. And I want to thank you all for being here today and continue to join us for our very informational webinars. Everybody have a great day. Thanks again, Elisa.
Thank you.
Bye, everybody.